Good morning, everyone. I would like to welcome you all on behalf of INTAS today for today's session, which is on when your cells go missing, unraveling the mystery of pancytopenia. I would like to begin the session by thanking Dr. M.B. Agarwal sir for providing us this platform where we can discuss and have such meaningful and insightful conversation and discussions. I would also like to introduce our today's moderator, Dr. Amit Khurana, who we all know is a highly skilled and experienced professional, and he has a decades of experience in the field of oncology. He also has a fellowship in bone marrow transplant and hematology, clinical hematology, and is an expert in managing the hematological and hemato-oncological patients. He's also experienced in performing bone marrow aspirations, bone marrow biopsy, and other hematological procedures. He also has an extensive experience in both autologous and allogenic stem cell transplants. So I would cordially welcome you, Amit sir, and I would request you to introduce our today's speaker, Dr. Basu, and also go ahead with the session.
Thank you, Vastavika. Just give me a second. Well, very good morning to all of you, and good afternoon and good evening to all of us who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Devdutt Basu from Pondicherry, and he's going to lecture us on when your cells go missing, unraveling the mystery of pancytopenia. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Chetan Damne from Mumbai, our guest speaker for the day, Dr. Devdutt Basu from Pondicherry, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 12th of October 2024, from 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time, we have Professor Dr. Vaishali Sancharawala from Boston speaking to us on autologous stem cell transplantation in AL amyloidosis. Where are we in 2024? And the following day, that is Sunday, 13th of October 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. French Time, we have Dr. Delphine Ria from Paris speaking to us on CML, the possible changes in the treatment of first-line setting in 2024 and 25. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Akshay Mandloy from Agilus Diagnostics Mumbai Reference Lab Mumbai, Dr. Amar Ranjan from IRCH AIMS Delhi, Dr. Amrita Saraf from Sir Gangaram Hospital Delhi, Dr. Archana Wazifdar from Sir HN Reliance Foundation Hospital Mumbai, Dr. Jyoti Sauni from Gujarat Cancer and Research Institute Ahmedabad, Dr. Mahesh Mandolkar from Dinanath Mangeshkar Hospital Pune, Dr. Navjit Malik from PGI Chandigarh, Dr. Nitin Dayal from Max Super Specialty Hospital Saket Delhi, Lieutenant Colonel Dr. Rama Hariharan from Command Hospital Lucknow, Dr. Richa Juneja from AIMS Nagpur, Colonel Dr. S. Venkateshan from Armed Force Medical College Pune, Dr. Savitri Singh from Postgraduate Institute of Child Health Noida, Dr. Sweta Rajpal from ACTRAC Tata Memorial Center Mumbai, Dr. Tara Roshni Paul from Nizam's Institute of Medical Sciences Punchakutta Hyderabad, Dr. Tushar Sehgal from AIMS Delhi, Dr. Varsha Vadera from Kokilaben Dhirubhai Ambani Hospital Andheri Mumbai, Dr. Vidisha Mahajan from PD Hinduja Hospital and Medical Research Center Mumbai. Now it's time to introduce our special guest and chief guest for the day. We have with us Dr. Chetan Damne from Mumbai. Dr. Chetan Damne is Professor of Pediatric Oncology at Tata Memorial Hospital, Mumbai. He completed his MBBS from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Varda. This was then followed by pediatric training from Cook County Hospital, Chicago. And because of his interest in research, he went to Penn State Hershey and completed a master's in integrative biosciences. Subsequently, he joined MD Anderson Cancer Center in Houston for his fellowship in pediatric hematology oncology. During his training, he was inspired by his mentor, Dr. Lawrence Cooper, and got interested in cellular therapy. He then moved to the National University Hospital in Singapore, where he worked as a consultant and was also involved in NK cell trials for AML and neuroblastoma with Dr. Dario Campana. After his return to India, he joined Tata Memorial Hospital and continues to work on cell-based therapies till date. In collaboration with Dr. Hassan at ACTRAC, the team has developed cytokine-induced memory-like NK cells for AML. He is also working on the other cell-based therapies that are in early preclinical development. He is interested in applying technologies to solve challenges in pediatric leukemias. With a data manager team at TMH, he has developed an app to track maintenance therapy for outstation children with ALL. He is also interested with newer therapies for AML and is working on the AML registry for pediatric AML. It's my privilege to welcome Dr. Chetan Damne to inaugurate our webinar and give some words of wisdom. Over to you, sir.
Thank you so much, Kalpesh. Can you hear me?
Yes, sir. Please go ahead.
Oh, great. So it's indeed a privilege to be on this dais with so many eminent hematolo-oncologists from all over the country and people joining from across the globe. Of course, you know that we have moved a lot in the last so many decades in the management of leukemias as well as other hematological and solid tumor malignancies. But what I would like to share with friends today is that you are at a cusp of a lot of developments that are going to happen in the next few years. And especially for students, they will be treating oncology in a totally different way than we treat today or have been treating for the last 5 to 10 years. There's a revolution of immunology that has come in. And this, I would like to draw an analogy because now I'm sitting in at the Bangalore airport and I'm still able to connect with you. That a book by Thomas Friedman, who is a New York columnist and involved in world affairs. So what he says was that after the dot-com boom, there was a lot of investment with the internet available freely. And that has made California and Bangalore neighbors. And that is what he called flattening of the world. With that, there was seamless transformation of information from one place to another. People were able to interact and knowledge was no longer restricted to few people. Now, drawing this analogy in our field, if you see, previously, only those people who had access to journals in academic institutes were in the community did not have access to this or did not have the time to access this. Going forward, everything is now available on the internet and people can read and enhance their knowledge. What has happened now with the MHG seminars and so many other conferences that are happening in India, you get to interact with the people who are at the cutting edge of technology. And that knowledge is no longer restricted to academic centers. If you're sitting in a third tier city in India, you still have the same knowledge that anybody in Tata Memorial Hospital or AIMS New Delhi or in CMC Vellore has. So you are not at the receiving end. You can interact freely with the world's experts and you can give your opinion, you can ask them questions, and you are free to practice what is going on in the world, the latest things that are going on in the world. So if you want to do something going forward, you are no longer restricted to be in an academic institute. Now you see CAR-T is available in certain centers, but now there are private centers in Mumbai and so many other places that are able to deliver CAR-T cell therapy. So it is no longer restricted to academic centers. So this is a small revolution that is happening, and this will level the field between academic institutes across the country and all the people who are practicing hematology oncology all over the country. So now it is a level playing field because everybody has access to information, the therapies that are available only to academic institutes are now available to everybody. We would like to encourage everybody, especially the young generation, to do is to collaborate among yourselves, among your friends, among your colleagues. Okay, so that trials are not restricted to academic centers. They can come from collaborations between smaller institutes. Okay, and that will be a driving force for more innovation. And in the next 5 to 10 years, we will see a sea change in the way we manage oncology, not only in academic centers, but all over the country and even in private setups. So there's a lot of exciting thing going on. The access to technology and the development of technology that is being developed indigenously, the immunotherapies that are going to come up in the near future is going to change the way we treat our patients. So all the best, and I look forward to this transition and wish everybody participates in this. And we are no longer working in vertical, individual or small institutes, but we collaborate, because if we collaborate, we can do a lot of things together. So my best wishes, and thank you once again for giving me this platform to interact with everyone. Thank you.
Thank you, Dr. Chetan Dhamne, for that wonderful words of wisdom. It means a lot to us. And thank you for joining us as our chief guest for the day from the Bangalore airport. Thank you. Let me share the screen again. Now it's the time to introduce our guest speaker for the day. We have with us Dr. Devdutt Basu from Pondicherry. Dr. Devdutt Basu doesn't require any introduction. He's a very well-known figure, but it's my formal duty to introduce Sir. Dr. Devdutt Basu sir is Professor of Pathology at Mahatma Gandhi Medical College and Research Institute, Pondicherry. He did his MBBS in 1985 from Maulana Azad Medical College, Delhi, followed by MD Pathology in 1990, again from the same institute, Maulana Azad Medical College, Delhi. He was also the former professor and head of pathology at JIPMER, Pondicherry. He is also fellow of Indian College of Hematology, and he has about 229 publications and an interest in hematopathology and medical education. Today, he's going to give us lecture on when your cells go missing, unraveling the mystery of pancytopenia. Well, thank you so much. I stop over here. Over to you, Dr. Devdutt Basu, sir.
Good morning, everyone, and thank you, Dr. Agarwal and Dr. Amit, for introducing me and getting me on this platform. This is probably my second or the third thing with all of you. So without wasting further ado, I think without much time, let's start the thing. Let me share my screen. Yeah, is it visible now?
Yes, sir. Perfect.
So shall I start? I'm audible as well, I hope.
Perfect, sir. Please go ahead.
Yeah, all right then. So here we go. What I have in store for you for the next maybe 45 minutes would be a discussion on pancytopenia. And, as a pathologist or as a budding training pathologist or even as a clinician, I think a lot of it is fitting in the puzzle, fitting in the pieces of the puzzle to get to your diagnosis. So I thought we'd have some kind of a case-based discussion on how we solve this riddle of pancytopenia. So this is a normal smear. I mean, all of you who are looking at smears would know whether it's a normal smear. You have the RBCs, you have the WBCs, platelets, etc. And when your smear looks like this is what is pancytopenia. The RBCs are more scattered, less dense, WBCs missing, platelets missing. So that's pancytopenia. So let's start with some basic facts. By definition, pancytopenia means when your hemoglobin is less than 10, total count less than 4,000, platelets less than 1 lakh, and all three have to be there. However, in the presence of a normal TLC, at times you have pancytopenia, quite a lot of times, especially in the field of oncology, when your count may be normal, but your neutrophils go down. There is neutropenia less than 1.5 or 1,500 per cubic millimeter. So that's how we define pancytopenia. So what is in store for us? The plot is basically going to be case-based, and we will look for clues. Look for clues in the clinical scenario, look for clues in the peripheral blood. And since I'm a pathologist and a morphologist, I will talk a bit in detail on the marrow, to ascertain how to go about a pancytopenia with the marrow. Of course, currently there are many other laboratory tests which give us good information about the diagnosis and hope to unravel the mystery of pancytopenia. Again, some theoretical stuff for us to understand what are the underlying mechanisms for pancytopenia. So basically, why do cells go missing? Decrease in hematopoietic cell production. They're not being produced at all. Classic example, aplastic anemia. Or the marrow growth is suppressed. The marrow growth and differentiation is for some reason suppressed. It's not just decreased, it's also suppressed, like you get in myelodysplastic syndrome or aplasia as well. Ineffective hematopoiesis with cell death within the marrow. So that could also lead to pancytopenia, MDS, megaloblastic anemia, and that's what happens in this, where there is intramedullary destruction. Or the marrow is replaced by abnormal cells, the abnormal cells, metastases, granulomas, etc., which can go into the marrow and infiltrate and initially cause what is called the myelophthisic anemia, leukoerythroblastic blood picture, followed by pancytopenia. Or the cells are being produced from the marrow, but they are getting removed from the circulation because they're defective production. Megaloblastic anemia, classic example. Or there is antibody-mediated sequestration or destruction of the cells. Or finally, the cells which are being produced from the marrow get trapped into the in the hypertrophic or overreactive reticuloendothelial system. Classic example of what we get in hypersplenism. Okay, so these are the basic underlying mechanisms for pancytopenia. So that's what we have to identify, whether they are getting killed or they are not being produced or they die themselves, right? So what are the tools that are available with us when we discuss or when we deal with a case of pancytopenia? The CBC is very useful. Retic count of paramount importance. Peripheral smear examination to pick up clues. Bone marrow. Immunology and biochemistry also helps. In certain cases, you need to look at the antibodies, you need to look at the biochemical parameters, and that helps. Flow cytometry and immunophenotyping in some conditions like flow cytometry, especially in the benign processes, we will discuss that. Of course, currently there is a tremendous role for cytogenetics, FISH, and molecular. In certain situations, we need their role. And overriding everything else is a good clinical input, looking at the patient properly to ascertain the cause of your pancytopenia. So just a few words for those who are not familiar or those who are starting off with observation or morphology, assessing the marrow cellularity. You know that we look at the particles in an aspirate, and depending on the rough ratio between the hematopoietic cells and the fat, we assess it. So what is this on the left panel? Wait, just a minute. Fine. 1 second. Okay. On the left panel is the one which would be called as a hypocellular if it were a young person. So depending on this, we assess the cellularity, right? Similarly, a trephine biopsy is better equipped to tell us about the cellularity. What is in a child, the cellularity is in a child is much higher than what it is in an adult, and the cellularity goes down normally as we age. So rough dictum that we have is this 100 minus age, which is kind of useful for assessing the overall cellularity. When interpreting a trephine biopsy, it is important to also identify something called the first fat space. The first space right adjacent to the trabecular bone is usually full of fat, and that's normal. Whatever be the age, it usually has some fat spaces. So what you see is, and that is the area where the cellular cells proliferate or cells fill up the first fat space. So if you have the first fat space is gone, it's likely to be a hypercellular marrow. So that's one thing we need to look at. And also be aware of the fact of something called a subcortical hypocellularity. The subcortical hypocellularity means that the first two space just after the cortex, periosteum cortex, is always hypocellular. It's hypocellular than the rest of the marrow. You can see that in this photograph. This is what is there on a higher magnification. The first space is hypocellular, but this is the actual cellularity of the marrow. So that is why whenever we are getting a trephine biopsy, we need to have an adequately long trephine biopsy, at least 1.52 centimeters. A small segment of a biopsy or a part of a bone marrow biopsy, which is just subcortical, may be hypocellular, and that could lead to diagnostic issues. You should not misinterpret that as a hypocellular marrow. So with these 2 points, let us just come to what are the causes and how do we look at marrow in pancytopenia. When we are discussing marrow in pancytopenia, there could be either hypocellular marrow, or the marrow cellularity may be normal or even hypercellular, and that could be due to something like because of marrow diseases or systemic diseases. We'll just go into in slightly more details. So pancytopenia with a fat-rich marrow. The classic example is aplastic anemia. Or a constitutional marrow failure syndromes. Some of the hypoplastic MDS or acute leukemias can present, often are fat-rich. Hypoplastic PNH is fat-rich. Post-therapy, marrows are hypocellular marrows. Transfusion-associated GVHD, a dreaded complication of transfusion, could also result in a hypocellular marrow. Or you might get an aplastic crisis and hemolytic anemia, which though generally is just red cell aplasia, but it could also have an entirely hypocellular marrow. So these are the causes of pancytopenia with a fat-rich marrow. When the marrow is cellular, what are the causes of pancytopenia with the marrow is cellular? This could be divided into 2. One is pancytopenia with a primary pathology in the marrow. All your aleukemic and subleukemic leukemias. There, the marrow is full of cells, but your peripheral blood often shows pancytopenia. Hairy cell leukemia, myelodysplastic syndrome, myelofibrosis, multiple myeloma, NHL infiltration, all these are part of your cellular marrow with a marrow pathology. You could also get pancytopenia with a cellular marrow, but in certain systemic diseases. Again, common example, hypersplenism, B12 folate deficiency, disseminated infections, tuberculosis, HIV, Kala Azar, hemophagocytic lymphohistiocytosis, connective tissue disorders, metastasis, storage disorders, or entities of myelonecrosis and serous atrophy. We'll take up cases one by one of all these entities and try and see how it works. So let's start with some cases. As we go on to these cases, you just please try and identify the important points that are there, which helps us in the diagnosis. So the first case was a 28-year-old man who presented with pallor and gum bleeds, 3 months duration, exertional dyspnea and gum bleeds. There is no significant past history. He had pallor. He was febrile, and on clinical examination, there was no organomegaly, especially splenomegaly. So we have a patient with features of anemia, some bleeds, and febrile. So this is usually the triad of the 3 clinical presentations of pancytopenia. So his hemoglobin was 3, TLC was 1.4, that is 1400, platelets was 22,000. And this smear showed a picture like this. So what do we see? We see a platelet, a single platelet, and we see a lymphocyte. So when we do the differential count, it came to N of 20 and L of 80. Okay, so lymphocytic preponderance and a neutropenia of 280 per cubic millimeter, right? So what next? What would we do next at this point of time? We would do a retic count, right? The reticulocyte count here was less than 2%, 0.2%, corrected was less than 1%, absolute retic count is roughly around less than 20,000. So there is reticulocytopenia. So the smear showed anemia, usually kind of normocytic to mildly macrocytic. TLC was low, ANC was low, platelets low, and the reticulocytopenia. So what do we do next? Obviously, the next line of treatment at this point of time, we've ruled out other causes, is a bone marrow. Now, this in a 28-year-old male, if you see a particle like this, it's hypocellular, right? In aplastic anemia, the marrow is often particulate. You can aspirate particles, but they are all hypocellular. And what does it show? It showed a few plasma cells, few lymphocytes, and hardly any hematopoietic cell hanging around. Again, pictures of a plasma cell, mast cell, some macrophages here and there, but on close observation, there was no hemophagocytosis. Some nuclear debris, etc., were trapped inside. So this was a general picture. So when we do an aspirate, it's always, as you know, simultaneous refined biopsy is done. And this was the refined biopsy picture. Markedly hypocellular, hardly any hematopoietic cells. But yes, there are these few foci of what are called the hotspots where some amount of hematopoiesis can go on. but bulk of it is suppressed, few lymphocytes and plasma cells. Here and there, we observed few hemosiderin-laden macrophages. Here and there, you see this golden brown colored pigment that is basically part of aplastic anemia. If you do an iron stain, they are often increased, and you come up with a diagnosis of aplastic anemia, consistent with an aplastic anemia. Okay. So by definition, as you know, it's pancytopenia with a hypocellular marrow. There has to be no abnormal cells, no increase in reticulum. That's how it is. It's a fairly common disorder and increasingly becoming higher, especially in the Asian population. It's biphasic. Most of the time it is acquired and we are not able to pinpoint the cause. About 50% of aplastic anemia becomes idiopathic. We really do not know. So as you know, again, I will not go too much into the theory. This is a recent article in the British Journal of Hematology on basically guidelines for diagnosis and management of adult aplastic anemia. And as you know, we divide aplastic anemia for the purposes of management onto 3: severe, very severe when your neutrophil is less than 200, and non-severe when it doesn't fulfill the criteria of severe or very severe. So what are the clues in the peripheral blood? Peripheral blood usually shows pancytopenia with preservation of the lymphocytes. The earliest to fall is platelet counts. There's reticulocytopenia, mild macrocytosis of about 100 to 105. Mild anisopoikilocytosis is common. Polys may show toxic change. Platelets are reduced, but there's no anisocytosis of the platelets. What you should not see in a case of aplastic anemia are polychromatophils, nuclear RBCs, tear dropping, microcytic hypochromic, left shift in the neutrophils, immature myeloid cells, bizarre or giant platelets. So once you have this kind of a peripheral picture and do not see these, you are more likely to think of aplastic anemia as the cause for pancytopenia. Bone marrow aspirations, as I said, are easily obtained fragments and they are hypocellular. This erythropoietic is in the erythroid series is common, may be common, but myelopoiesis and megakaryopoiesis should not show any dyspoietic change. Overall, all the 3 lineages are suppressed. There may be lymphocytes increased, plasma cells, macrophages, mast cells. Hemophagocytosis may be seen. Be careful. We have seen a few cases which do not fit into a HLH picture, but generally the marrow cells, as they're dying out, are taken up by the macrophages. And iron levels, iron stores are usually increased. So that's a typical aspiration finding. In a trephined biopsy, it's essential. Now, without a trephined biopsy, you probably wouldn't be able to diagnose with confidence aplastic anemia. And as I said, you need an adequate length of at least 2 centimeters. Be aware of the subcortical hypoplasia. And by definition, overall cellularity has to be less than 25% of the age. At times, there may be patchy. You might get focal collections of hematopoietic cells, which are called the hotspots. You might even get lymphoid aggregates. But reticulin stain, when you do it, is not increased. So in the clinical history, as I said, anemia and bleeding are more common. Features of infection are less often they present. No lymphadenopathy or no splenomegaly is the feature. Here comes the first rider. Does age matter in your diagnosis of aplastic anemia? Yes, it does. So we'll take up another case of a similar story, but it was in a 12-year-old boy. A 12-year-old boy presented with high-grade fever for 1 week, cervical lymph node and hepatosplenomegaly. There was no significant family history, 3rd-degree consanguineous marriage she was born out of, and had a younger sibling who was just 3 months old. He also presented with, on examination, he had cafe au lait spots and triphalangeal thumb. Now, this is the current story of this boy. 4 years ago, when he was 8 years old, he presented to us with a hemoglobin of 8, MCV of 106, WBC 2,500, ANC low, platelets 30,000, retic of 0.2%. And the peripheral blood showed pancytopenia without any atypia. Classic pancytopenia with lymphocytic preponderance. Bone marrow was hypocellular, showing suppressed trilineage hematopoiesis, no dyspoiesis, no atypical cells. The biopsy was typically hypocellular for age. And we called it consistent with aplastic anemia. An 8-year-old boy, when he presents with aplastic anemia, I hope all of you are aware, you must look for constitutional aplastic anemia. In fact, So this child was diagnosed as Fanconi with stress cytogenetics done. He was confirmed to be a Fanconi anemia. He was going on for 4 years on symptomatic management. Currently, 4 years down the road, his TLC shot up to 44,000 and you saw blasts. Okay. The bone marrow aspiration and trephine and the flow was compatible with an acute myeloid leukemia. So it was an AML that arose in a setting of a Fanconi anemia. So constitutional bone marrow failure syndromes have to be kept in mind when you're dealing with not just childhood aplastic anemia, but the guidelines say up to 40 years, because Fanconi anemia can present much later in life. So if you're dealing with a aplastic anemia, not aware of, not sure about what is the cause for it, I think the general guideline is go ahead and look for Fanconi or look for a stress cytogenetics and rule out a constitutional bone marrow failure. Not just Fanconi, disc keratosis congenita can also present. They have classical skin lesions, etc., leukoplakia, nail dystrophy. They can also present up to the age of 25 to 26 years. So this is the list of the various causes of bone marrow failure. The one on the left is pancytopenia. In all of them, Fanconi, disc keratosis, Schwachman-Diamond, amegakaryocytic thrombocytopenia in later stages. These are the ones that present. Diamond Blackfan presents with red cell aplasia, Kostman with neutropenia, and thrombocytopenia with amegakaryocytic thrombocytopenia TAR. Okay. However, Kostman, all of these could shift towards pancytopenia at a later date. So there may be some kind of an overlap, especially between Schwachman-Diamond syndrome, between neutropenia and all. So these are the list of things which has to be kept in mind. So look for the clinical features, look for the cytogenetics, look for the molecular to help you in diagnosis. So generally less than 40 years, currently you can do sequencing, peripheral blood leukocyte telomere length, all these are possible. So this is how you will go about ruling out the constitutional bone marrow syndromes. We had this another case, as I said, age matters. Now he is adult, he is more than 40 years. He presented with fatigue, features of anemia, no organomegaly, some vague history of jaundice. Again, pancytopenia, hemoglobin of 9.5. Now notice, if you look at it, there is a slight difference between this and the previous cases. Here you have a reticulocyte, which is about 3%. Also, the indices are microcytic hypochromic in contrast to macrocytosis. And there are a good number of neutrophils. It's not that the neutrophils are totally suppressed, totally wiped out. Okay. So there are some differences between this kind of a pancytopenia with the previous one. Right. So we went ahead, did a marrow. The marrow was kind of hypocellular, but if you notice, there were these clusters that were visible. Erythroid colonies were still persistent here and there. Myelopoiesis and megakaryopoiesis was suppressed. And we did an iron store and that was negative. So what do you think of when you get a patient with pancytopenia, but erythroid is there? There's another thing that you can think of. Bone marrow trephine was also hypocellular. But the effect, these hot spots that were there, they were more prominent. And it was not a very uniform hypocellularity. You had a lot of patchy cellularity. In fact, these are the 4 pictures taken from similar cases, showing the variation in the marrow cellularity that can happen. And all these areas are basically erythroid cells, few lymphocytes and plasma cells, of course, that are there. So when you have an aplastic anemia in an adult more than 40 years, look for PNH to be investigated. Up to 2/3 of patients with aplastic anemia can have small clones of PNH cells. 30% of PNH patients have a preceding aplastic anemia. Aplastic progressing to clinical PNH is less frequent, but does occur. So you can, at a setting, you can do this. What is this test? It's basically urine for hemosiderin. Often comes out positive nicely. And of course, you don't do hams anymore. Flow cytometry or FLAIR can be done to diagnose PNH. So if you have the clinical suspicion, go ahead and investigate for PNH. In a case of aplastic anemia, which is we are not getting the cause, you need to take up some other histories. History of jaundice, post-hepatic, non-A, non-B, non-C, often is a cause for jaundice. History of drugs, very important. Various drugs, chemotherapy, not just chemotherapy, antibiotics, antirheumatics, anticonvulsants. Any of this broad list can present with aplasia. Occupational history, you had Mary Curie, classical example. She used to roam around with radium bars in her white coat pocket and around all over the place. And she had aplastic anemia and she succumbed to it. So radiation history is important. History of certain chemicals like benzene, pesticides, organophosphates. lubricating agents, recreational drugs, methamphetamine and ecstasy, both tend to cause aplastic anemia. Various infectious agents, Epstein-Barr virus, HIV, dengue, leptospira, cytomegalo, parvovirus can cause aplastic crisis, of course. So we have the 65-year-old lady, CA breast follow-up. Case of CA breast stage 3B, underwent radiation followed by chemotherapy 8 cycles, received a few PRBCs, post-chemotherapy 3 months, and her counts did not recover very well. Again, pancytopenic picture. So when you have a picture like this, you're wondering, is it therapy induced? By chance, is there metastasis? So you again need to do a bone marrow. Bone marrow in her was again hypocellular with stromal fragments, regenerating adipocytes and very few hematopoietic cells. Biopsy was also hypocellular, but there were clusters of cells here and there, patchily hypocellular. And so this is a case where you get drug-induced aplastic anemia. Post-chemotherapy in acute leukemia, we commonly see. Post-TKI therapy in CML, we are seeing visceral malignancies. Another dreaded complication that may happen over here is transfusion-associated GVHD, where there is marked suppression of the entire hematopoietic cells, and that has to be taken care of when you're diagnosing this. So before labeling a patient with aplastic anemia, confirm the diagnosis, exclude congenital aplastic anemia, screen for underlying causes of aplastic anemia, document underlying PNH score, and exclude other causes of pancytopenia with hypocellular marrow. All right. So that we move on to a very similar entity which often causes a diagnostic dilemma. And let's see that case. We have this 59-year male, fever and epistaxis. His fever was for 3 months. Epistaxis was there, severe pallor, petechial spots, no organomegaly. Again, came with a clinical impression of aplastic anemia. Hemoglobin was 3.5, total count low, ANC low. DLC was N30, monocytes were 5. Very similar to what you get in aplastic anemia, and the pancytopenia dilemma was there. Now, bone marrow, peripheral blood did not show too many abnormalities. We'll come back to this field a bit later, if you noticed, any of you. Aspirate was unsatisfactory. The trephine was patchily hypocellular. It was markedly hypocellular in areas, but some of the areas did show a lot of, cellularity. And here is one field, the hotspot that was seen, showed obviously a big cluster of immature cells, right? There they are mononuclear cells and blasts, in fact. Here and there we saw fairly dyspoetic, trilobed, lobe-separated megakaryocytes. Erythropoiesis was kind of suppressed, but it was there. There were these clusters of mononuclear blast cells. Now, in a trephine biopsy, you are often with a dilemma: are we dealing with an erythroid blast or a myeloblast, etc.? So we did an E-cadherin that was positive in clusters, definitely. There were immature erythroid cells. We also did a CD34 in this situation, and there were these good number of CD34 positive cells. And then you go ahead and do the cytogenetics, do the further workup, immunophenotyping. And this was a case of a hypocellular MDS or bar AML, depending on the CD34 counts that we get. Okay, so as this case, you have to look at cytogenetics, look at FISH, and give your diagnosis of MDS. So mind you, this is the scoring system by which we can differentiate aplastic anemia from hypocellular MDS. This is the various variables that are used. So it's important to do a CD34 count, either on the immunohistochemistry or on the flow cytometry. And if it's more than 5%, more than equal to 5%, be aware of the fact that it could be an MDS. So this is the various things that we look at. We look at the fibrosis, we look at this megakaryopoiesis, presence or absence of ring sideroblasts, severe dysgranulopoiesis, then presumptive cytogenetics and specific mutations that are there. Okay, so this is very important when you are observing the trephine biopsy to pay attention to the hotspot and do a CD34 if you feel it is necessary. Not that you have to do it in all the cases, but yes, if you spot out slightly immature cells, go ahead and do it. So this is your DD of pancytopenia with a hypocellular marrow. Okay, aplastic anemia and its group. Hypocellular AML or MDS, at least 5% of them can be positive, and CD34 is useful. Childhood hypocellular MDS is known, where hemoglobin F levels are raised. Hypocellular ALM, relatively less common than hypocellular AML, but yes, we do get cases. Hypoplastic PNH and drug-induced aplastic anemia. So this is what when we deal with pancytopenia with a hypocellular marrow. what we saw now were hypercellular was because of increase in fat. But could there be pancytopenia with hypercellular? Not necessarily fat-rich marrow. Just take a few examples of that. This was a 23-year-old male with jaundice. I've shown this case before in some other forums. It was a patient of sickle cell anemia who had fever, jaundice, very severe jaundice, and a tender hepatomegaly with a clinical impression of malaria query leptospira. His hemoglobin was 4, TLC was low with a 90% polymorphs. His bilirubin was sky high, 27.8 with a direct of 11.2. The peripheral blood showed sickle cells. That was there, but there was this little query as to why is there pancytopenia and why is there hepatic type of jaundice. So soon this patient was actually one of the various laborers who had come here to work in our hospital. His parents came when he was sick, and he was known to be a sickle cell, and 3 units of red cells were transfused, but the patient did not. He succumbed to the illness on day 2 of arrival, and postmortem liver and a bone marrow was done. The postmortem liver, I'm trying to show you here, showed congested sinusoids. More or less, the hepatocytes were normal. The sinusoids were congested. The portal tract was inflamed, definitely. And when we looked at the sinuses, you notice that they are, sickle cells, right? The RBCs are all elongated. The bone marrow was totally necrotic. There was necrosis of the marrow, and there are a few, we could spot a few blood vessels here. Notice this blood vessel with hypercellular, sickled RBCs. Another hyper showing that. So this was a case of a sickle cell in liver, sickle cell crisis in liver causing myelonecrosis. So myelonecrosis is an important cause for a pancytopenia with a hypocellular or a poorly cellular marrow. Similarly, there was another case, 22-year-old male with severe bone pain, fever, epistaxis, fatigue, pancytopenia. PS had a leukoerythroblastic picture. Bone marrow aspirate was unsuccessful, aparticulate degenerated. And the biopsy was this. Another area which is totally necrotic. Okay, there were no cells, coagulative kind of necrosis. Here and there, we did find some areas where blasts were there. There were necrosis, but foci of cellular foci were there here and there, and we found that blasts were present. The flow was inconclusive in this particular case. When we got the trephine biopsy, we applied the immunohistochemistry as a blood. TDT and CD10 turned out to be positive. We were able to diagnose it as a case of BALL. We published several such cases in our series a few years ago. So myelonecrosis is characterized by necrosis of the medullary stroma and the hematopoietic cells. Often the presentation is with fever and severe bone pain. Pancytopenia in 20%, leukoerythroblastic blood picture, and there are numerous causes: sickle cell, HIV patients, hematolymphoid malignancies at diagnosis. Tumor lysis syndrome can often present with myelonecrosis, metastasis, and tuberculosis. This 40-year-old lady who was a destitute patient living with HIV/AIDS again had pancytopenia. 4.3 TLC low, and peripheral smear was non-conclusive just for pancytopenia. The aspirate was poorly cellular, but you had these bright eosinophilic kind of material around the fat spaces, which were positive for Alcian blue. The biopsy was again totally devoid of any cells, excepting for these eosinophilic material around the fat spaces. And this was a case of another case called gelatinous transformation or serous atrophy. This is basically replacement of fat and hematopoietic cells with extracellular matrix, and again has a wide variety of causes. Anorexia nervosa is one, cachexia secondary to any of the conditions, renal failure, celiac disease, etc. It is quite often that we are starting to get gelatinous transformation, especially post-therapy, etc. also. So basically, you have pancytopenia, sometimes acanthocytes may be present. Bone marrow aspirates are often difficult to spread. Amorphous material is there, which are acid mucopolysaccharides, and the trephine biopsy is needed to diagnose. We have certain publications that we have done out of it. It's a disease entity that we keep getting often now. Another cause of a pancytopenia, but something else in the marrow, hypocellular marrow, and this was a 65-year-old lady with massive spleen. So this is another clinical scenario which sets apart the causes of pancytopenia. Again, counts are low, but here in the peripheral blood, we had close teardropping of RBCs. You see a blast here and there. You see NRBCs in plenty. So you're dealing with a pancytopenia with a kind of leukoerythroblastic blood picture. So elderly lady with splenomegaly, often you should be able to think of what you have. The bone marrow aspirate was a dry tap. Okay, it was totally dry in this particular case. It need not be always dry in all cases, but here it was totally dry. And the biopsy showed increased fibrosis. You can see the streaming, clusters of abnormal megakaryocytes, and you know what you're going to diagnose. Dilated sinuses, streaming, increased fibrosis. At times, you might get even osteosclerosis, new bone formation, and your reticulin is high. The reticulin stain, the trichrome is high, showing collagenization, and you diagnose primary myelofibrosis in this particular case. So pancytopenia with leukoerythroblastic picture usually means that there is a fibrosis in the marrow. So primary myelofibrosis, other myeloproliferative neoplasms in the spent phases, in the late phases, may present with a lot of fibrosis. Metastasis and other infiltrative disorders often cause a lot of fibrosis, and you have a leukoerythroblastic picture with all the 3 cell counts on the lower side. That was in a 65-year-old woman. This is now in a baby, a 3-month-old baby with massive hepatosplenomegaly, suspected of storage disorder. Again, you have a leukoerythroblastic picture. The bone marrow aspirate was devoid of hematopoietic cells, but showed clusters of osteoblasts. And the trephine biopsy was like this. There was this lots of broadened spectrum of the bony trabeculae lined by osteoblasts with immature and kind of cartilage that was, kind of immature and was going on all over, inadequate cartilage. And notice also there are presence of osteoclasts over here. X-ray done and you diagnose osteopetrosis, marble bone disease. So again, another case of a 60-year-old male, retired rank officer on hemodialysis. He had refractory anemia persistently and went into pancytopenia. Other differentials, okay, no atypical cells, retic is about 1%. This was on the left panel is the peripheral blood, and the right is a diluted kind of a marrow where you see hematopoietic cells, where you see a few here and there are myeloid cells, including a blast. You're really not sure of what you're dealing with till you get to the bone marrow trephine. The bone marrow trephine here shows, notice, the scalloping of the bony trabeculae, increase in osteoblasts, lot of fibrosis, lot of osteoblastic proliferation, scallop. You have fibrosis going on. Hematopoiesis is happening, but not very regularly. Paratrabecular fibrosis. You do a reticulin and you do a trichrome and you identify this kind of fibrotic pattern, scallop trabeculae, osteoclastic activity, peritrabecular fibrosis, and you're dealing with a renal osteodystrophy. So this is again a cause that can lead on to, in severe, to pancytopenia. So disorders of bony trabeculae are also to be kept in mind when you deal with pancytopenia. Osteopetrosis in a child, osteopathies various like renal osteodystrophy or Paget's. Osteomyelosclerosis can be seen in spent phases of myeloproliferative and metastasis. So these are, as I said, the various morphological spectrum of pancytopenia with a hypocellular or a paucicellular marrow. Right, so fat-rich, myelonecrosis, serous atrophy, and fibrosis and osteosclerosis. Let's move on to the second group, with a 5-year-old child presented with pain in the knee joints for 1 month, weakness and fever, and juvenile arthritis was suspected. Peripheral blood showed blasts, right? Marrow was full of blasts, and you do a PAS, you do the immunophenotyping, and you diagnose trephine biopsy positive, TDT positive. Immunophenotyping in this particular case was an MPAL, B myeloid acute leukemia, and that was an acute leukemia presenting as pancytopenia. The peripheral blood didn't have flows. Similarly, a 15-year-old girl with menorrhagia. Typical menorrhagia, bleeding spots all over, low counts, and you look at the peripheral smear, and here is the clue to you or diagnosis of promyelocytic leukemia. So just look at the cells that are there in the peripheral blood. You can pick up promyelocytic leukemia, and that's an emergency kind of decision that you have to take. So do a Sudan black, follow it up with cytogenetics and the FISH 1570. So some acute leukemias do present with pancytopenia, about 10 to 20%. Then this condition is called a subleukemic leukemia or an aleukemic leukemia. ALLs more than AML, BALL about 20% of them. Childhood acute leukes more often than adult present with pancytopenias. Amongst the AML which present with cytopenias are M7, M3, panmyelosis with myelofibrosis, or AML in a background of myelodysplasia related changes. So we have this elderly man with pancytopenia now. So again, an old army man residing in an old home, presented with pancytopenia features, and the peripheral blood showed this. Remember the other case also? These are Pelger-like neutrophils. Here and there, an occasional blast. So you're now dealing with a MDS. And look at this, for an 80-year-old, a very severely hypercellular marrow. You had dyspoetic myeloids, erythroid cells, almost megaloblastoid in origin in their thing. The aspiration showed a few clusters of blasts, myeloblasts, not too many. The iron stain done was replete with iron. And when you look at the oil immersion, you find that there are ring sideroblasts. So you know you're dealing with a MDS. The trephine biopsy shows these immature cells, and the ones with a linear kind of nucleolus, right? These are the ones that are possibly erythroid. So you do an E-cadherin, which is positive. You do CD34, which shows you the ALIP, the increase in the blast, not to more than 20%. This megakaryopoiesis, in this case, CD61 showing clustering and very abnormal looking megakaryocytes. So you have this case, and then you do a cytogenetics, which is hyperdiploidy in this particular case, and you know you're diagnosing an MDS. So MDS, about 75 to 80% of them present with pancytopenia. Currently, we are aware of these pre-MDS states. I hope the juniors would be seeing them more and more often. We will now be able to see of these four things that we have: idiopathic cytopenia of undeterminate significance and clonal cytopenia of undetermined significance, both present with peripheral cytopenias. All right. The other two, the idiopathic dysplasia and the CHIP, do not necessarily have cytopenias. A 70-year male with a big spleen, again, no free fluid. And this one, the little difference is that a prominence of lymphocytes. So now we have a case of pancytopenia with lymphocytic predominance and atypia of the lymphocytes. And this is classically, not to be missed, a hairy cell leukemia. Typical fried egg appearance, chicken wire type of fibrosis that you get, BNHL, hairy cell morphology, reticulin here, and CD20, and you can work up for a hairy cell leukemia, either on flow cytometry or on your trephine biopsy, IHC, and you can diagnose hairy cell leukemia. This 80-year male presented with pancytopenia and splenomegaly. Okay, again, low counts, ANC is also low, aspirate was totally dry. And this was an interesting case, fairly cellular marrow. If you notice carefully now, there are hematopoietic cells, but just have a look at this field. I'll show you the next field. Notice these little blood vessels, which are filled with some cells, okay, atypical cells, only in the sinuses. You do a CD34, and it highlights the sinuses. You do a CD20, and it shows what is called an intravascular B-cell lymphoma. This 60-year-old lady also had a similar pancytopenia. Otherwise, no pallor, no organomegaly. And again, a teardropic kind of leukoerythroblastic blood picture. She was also investigated simultaneously and showed a creatinine elevated, total proteins increased, AG reversal, urine proteinuria, and a chronic kidney disease, and suspected to be myeloma, though she did not present with bone pain or lytic bone lesions. Bone marrow aspirate was kind of imprint, was kind of cellular, and showed plasma cells. The trephine biopsy, in addition, showed amyloid. Okay, so CD138, and we were able to diagnose it as a case of multiple myeloma with amyloid. So pancytopenia in the hematolymphoid malignancies could be, as I talked about, MDS and aleukemic and subleukemic looks. In the lymphoproliferative ones, hairy cell, hepatosplenic T-cell lymphoma, and NK T-cell leukemias present with pancytopenia. Diffuse lymphoma infiltration, amyloidosis, fibrosis, myeloma can cause pancytopenia. And so therefore, associated necrosis and fibrosis compounds the cytopenia in all these hematolymphoid malignancies. So let's now look at pancytopenia with a cellular marrow. We have discussed all of these. We are now left with the pancytopenias in a systemic disease. Now, these are more often we see. Many a times we need not do a marrow, but we do get cases. So there was this 35-year-old male, known case of chronic liver disease, presented with repeated bouts of hematopoiesis, ascites and spleen. So we are dealing with a case of hypersplenism. Hemoglobin is 6, the MCV is low because of probably his repeated blood losses. Retic was okay. But here again, notice his retic is okay, TLC is okay, platelets are reduced, all of it is reduced. Microcytic hypochromic blood picture with low counts. The bone marrow was erythroid hyperplasia, and this is what is seen as micronomoblastic erythropoiesis. Notice vacuolation in the cytoplasm. There are few causes of vacuolated cytoplasm, the commonest being iron deficiency anemia. You do an iron store and it is 0. So this is the appearance of a micronomoblastic erythropoiesis. Predominant late normoblast, small in size, etc. So what next? Do an iron, it's grade 0. And you diagnose it as peripheral cytopenia, cellular marrow with erythroid hyperplasia. In a setting of cirrhosis and spleen, you could label it as a hypersplenism. So you get a reactive marrow in some situations. Apart from hypersplenism, you can get it in hyperreactive malarial serology, connective tissue disorders, and non-specific infections. This postmenopausal lady was a 67-year-old. She was a retired school teacher. She lived alone, was a strict vegetarian. On examination, she had pallor, no other significant finding. And here her MCV was 112, TLC was low, retic was also low, platelets were also low. And this was the peripheral blood picture. Hypersegmented neutrophils, macrovalocytes, etc., Howell-Jolly bodies, etc. So she was started on empirical vitamins, but she could not afford getting the B12 folate levels. And when she came back to us again, her hemoglobin hadn't significantly increased. So did not increase. So there was a thought of, is it an MDS that we are dealing with? And the bone marrow was done. The bone marrow showed kind of macronomoblastic. She had received some B12 and folate. So typical megaloblasts were not there. Currently, we don't get to see them. But definitely abnormal erythroid cells were there. But there was no dysmyelopoiesis or dysmegakaryopoiesis to suggest an MDS. Iron was prominent. Biopsy also showed erythroid hyperplasia, megaloblastoid erythroid hyperplasia. CD34 was positive, negative. E-cadherin was strongly positive. So this was probably an inadequately treated megaloblastic anemia. There was lack of compliance. Now, when she was put on a monitored therapy, she came out, did really well, and her hemoglobin was back to near normal when we last saw her. So currently, we don't have the bone marrow as an indication for megaloblastic anemia. When we were students, the most important indication was a case of macrocytic anemia to rule out megaloblastosis, because your serum levels are available. Many a times, empirical treatment and surrogate rise in hematinics is taken as a diagnosis. It is to be done more often when you are it's refractory to treatment, or elderly patients, MDS, you're suspecting, post-chemotherapy response assessment, you find megaloblastic anemia. Pancytopenia with fever. This was a patient with a high spiking 15-day fever, mild splenomegaly, and showed a lot of plasma cells, the aspirate, and hemophagocytosis, right? Histiocytes with platelets, nuclear RBCs, neutrophils, etc. The biopsy also showed a large number of hemophagocytes, CD168 or CD60. If you want to do, it's not really necessary, but we did it for an academic purpose. So HLH, it's a potentially fatal disorder. I am not going to go into the details. You know the presence of the 2004 guidelines and currently the X score that we prefer to do. And it's an important disease, needs active management to be diagnosed. So this was another patient, 30-year-old male, fever with pancytopenia, HIV positive. This patient with pancytopenia. Bone marrow was done with an indication of cytopenia and fever, which was not being diagnosed otherwise. Aparticulate, sparsely cellular marrow, but showed what are called negative images, stained with AFB, and it's positive. There were intracellular bacilli, extracellular bacilli, and Mycobacterium avium intracellular is PAS positive. So you could able to diagnose that as well. Trephine biopsy shows sheets of foamy macrophages positive for acid-fast bacilli. It could also be many other infections could present with pancytopenia. This is a malaria gametocyte with hemophagocytosis, Kala Azar, LD bodies in the biopsy, histoplasma, cryptococcus. So all of these can present with pancytopenia. The list is pretty long when you have fever as a prominent finding in pancytopenia. 22-year male, young male, this case also I have discussed earlier, who presented with pancytopenia but showing a picture of microangiopathy. You see the schistocytes in this field. We did a bone marrow, investigated for MAHA or DIC, picture was all negative. Bone marrow was done, which showed metastasis. Okay, this is the biopsy showing a mucin secreting kind of adenocarcinoma, musicamin positive, CK7 positive, CK20 negative, investigated and turned out to be a biopsy-proven adenocarcinoma of the stomach, which had involved the bone marrow and presented with pancytopenia. So metastasis can present with leukoerythroblastic picture and pancytopenia, and many of these visceral malignancies, childhood tumors, neuroblastoma can present with metastasis. This 5-month-old boy, massive hepatosplenomegaly and pancytopenia, showed certain clues in the peripheral blood, new vacuoles in the lymphocytes. So you're dealing with a storage disorder. Positive for storage cells, for me, macrophages. We did an X-ray, bilateral adrenal calcification, and Wolman's disease. So any of these storage cells, whether it be Gaucher or Niemann-Pick, C-blue histiocytosis, etc., can manifest with pancytopenia. So all these storage disorders, again, look for delayed milestones, cherry red spot. 50% often have pancytopenia. So these are the causes of pancytopenia with splenomegaly: congestive portal hypertension, reactive marrow, Kala-Azar, myeloproliferative neoplasms, lymphoproliferative neoplasms, and storage disorders. The last case was an interesting case of a 20-year-old female who presented with multiple lymph nodes, no organomegaly, and reactive lymph node on FNAC. Peripheral blood was pancytopenia, and no abnormality. ESR was elevated. Bone marrow was a cellular marrow. So not a very good particulate marrow, but not good trails, but they were there. And then my resident spotted these. I have again shown these pictures before, LE cells. In oil immersion also. So we were able to diagnose a case of possibly LE cell. We investigated for connective tissue disorders, and it turned out to be ANA positive with immunoblot showing features of LE cell, SLE. Core biopsy didn't show much, excepting it was showing a bit of fibrosis. Nothing else was there. So pancytopenia in a systemic condition, again, the whole lot can be there, and there are definite overlaps between each group of diseases. So when you discuss the clues to the cause of cytopenia, clinically, look at the age, look for syndromes, bleeding more than fever or bleeding less than fever, that also plays a role. Look for organomegaly, get a good history of drugs, toxins, radiations, exposure to infection, other organomegaly. But by and large, if you're leading with an aplastic anemia, most of them are still idiopathic. The blood smear offers good clues. CBC, ANC, whether it's less than 200 or less than 500. Look at the reticulocyte count, whether it's low, normal, raised. If you need to correct, you correct your retic and see if it's less than 2%. RBC morphology, whether they are macrocytes, whether they are microcytic hypochromic, teardropping, NRBCs. Differential count, is it a normal differential count, or is there lymphocytic preponderance? Count the ANC that is there, as I've said before. Are there left shift? Is there a hypersegmented poly? Are there abnormal cells, blasts, Pelger-Hue, vacuolations, hairy cell? Platelets, are they bizarre or are they looking normal to you? And parasites. So the various summary of investigations that play a role, from starting from CBC, blood film examination, to I've detailed a bit on the bone marrow. Do your cytogenetics, both stress as well as if you're dealing with an acute leukemia, the proper karyotyping to be done. Flow cytometry for PNH, vitamin B12 folate levels, liver function test, certain infectious etiology, the immunology, all these together will help you rationalize your investigation and arrive at a diagnosis. So the unraveling the mystery of the missing cells, pancytopenia, often presents a diagnostic challenge in both children and adults because it encompasses a wide variety of potential etiologies, or the suspects are quite a few. And a careful examination would help you in solving the puzzle. So last question, did you hear what happened to the RBCs, WBCs, and platelets? That's just a little bit of a trivia. My last slide. Well, they all had a marrow escape. Thank you very much for your patience. I know I've spent a lot of time on this, almost an hour. I'd be happy to field questions.
Thank you, sir, for the wonderful and fantastic talk. You covered almost everything, showed so many cases. That was beautiful. And I now request all our discussants to please put the raise hand sign so that we can start our question and answer session with Dr. Basu, sir.
Yeah, fire away.
So, yes, ma'am. Dr. Tara Rosni Paul, ma'am, your question, please.
Good evening, sir. Lovely talk. Actually, it's not a question,
Evening
but
is yet. I didn't go that long.
no,
Still afternoon.
it was
Yeah,
very good.
Thank you so much.
Just
Thank you so
want
much.
to emphasize the look, of course, the history and clinical details one has to pay attention to. The peripheral smears, there are such subtle clues in it. You alluded to
Absolutely.
most of them. And like, dysbiosis or in aplastic anemia, getting a few, the retic being high or polychromatophils, we have to do PNH screening then.
Yes,
So I
definitely.
think the
Definitely.
residents have to, at this point, has to be emphasized that screening properly of a peripheral smear to get even the smallest clues is extremely important when we are dealing with pancytopenia.
Yes, absolutely. Absolutely.
Thank you, ma'am. Dr. Amrita Saraf, ma'am.
Hi. So this was a very beautifully covered lecture on pancytopenia, and we know that day-to-day basis we keep on getting a lot of patients samples where we don't know what may be the cause of pancytopenia, and I think it has been wonderfully covered what all one should pay attention to and go ahead. So I wanted to make a comment, like sometimes we are not very happy with the quality of the smear. So I think rather than giving a differential or a peripheral blood picture on a suboptimal peripheral blood, we should always go for a better quality and better stained smear. And sometimes the turnaround time becomes a problem for us. But I think it's always good to feel satisfied with the quality of the smear and then go ahead. Otherwise, sometimes one can get confused and go ahead for unnecessary invasive investigations. And even the morphology, like sometimes there are these, say, atypical looking lymphoid cells or LGL cells, or what has been highlighted by, so it's like one has to pay attention to. And I don't think like any question is there, but it's the comment that it has been very nicely covered in this
Point is
lecture.
very well
Thank
taken. I
you.
mean, there is no substitute for a well-made smear.
Yeah,
Having said that, your differential count, most of our machines do give a good differential count, but these subtle morphological clues need to be picked up on a well-made peripheral smear. So there is no
right.
doubt about it. So that's why we say, suppose you want to beat the turnaround time, or don't pay too much attention to the turnaround time. Satisfy yourself that you're giving out a
Right.
good report. So that's important. And if the smear
Yeah,
has come from the wards and
definitely.
you're not happy with it, there's no harm in saying the smear is unsatisfactory. Let's repeat, or send someone and make a smear, or ask the patient to come to your ward and make, or to your lab and make the smear. There's no substitute for
Right.
a good morphological interpretation. That's true.
And
Very true.
sometimes the equipment, what it gives the result in terms of indices, that can also be confusing. So
Yeah, that you
yesterday's
have to
lecture
maintain
also
your
was like a
quality.
pointer towards that.
You have to maintain your
Definitely.
quality. Absolutely. Without that, there is no going ahead. Yeah. Thank you so much. Yeah.
Yeah. Thank you so much.
Thank you, ma'am. Somebody with Savipet 8, I think Dr. Savitri. Your question, please. savipet8@gmail.com is coming as that. You can ask your question. Okay. Anyways, Dr. Richa Juneja, your question, please.
Thank you. So thank you. It was such a beautiful talk and such a beautiful visual glossary for all the residents to go through the entire spectrum of pancytopenia. I would like to seek your input on one of the case we recently saw. So it was a 46-year-old female with a primary concern of splenomegaly, creating cytopenias. With that, she visited medicine, then hematology, etc. And every time the PS we do, it will show subtle leukoerythroblastic blood picture. Her marrow was already done twice outside. We reviewed that. We also repeated the bone marrow, and it was she was also having some lymph node. Initially, we thought probably extramedullary hematopoiesis, but then she underwent both bone marrow repeat and the lymph node efficacy. The bone marrow showed gelatinous transformation, and the lymph node showed granulomas. Now, her entire TB workup was negative, multiple times done again, and then her lymph node biopsy was also done. that again showed non-necrotizing granulomas. Her enzyme level, etc., finally concluded her as a sarcoidosis. However, she kept coming back to me why gelatinous transformation. I tried reading, we did Alsha and everything and proved it was gelatinous only. And probably that was creating little leukoerythroblastic blood picture. But then I read some cytokine mediated cause, but then there is no definite reported literature on this. So have you experienced such things, such coexistence of sarcoidosis with the gelatinous?
No, sarcoidosis we have not seen with gelatinous transformation. With tuberculosis, we have reported. We have seen it in HIV. We've seen it in a wide variety of situations. You're sure it was gelatinous transformation and not subtle myelofibrosis?
No, sir, we did all that. We did
all that was
reticulocyte
negative.
came negative and Alcian came positive. I intentionally did. Usually I won't do Alcian, but in her case, because everything was coming
Yeah, you have to do it.
doubtful,
Okay.
yeah.
All right. Maybe you could get it. How big was the spleen?
It was concerning, sir, like moderate splenomegaly
Moderate
creating
splenomegaly.
cytopenias, yeah.
Yeah, so possibly
Events.
also spleen must have also had sarcoid. What was the response of the patient?
Sir, recently treated with steroids and all. She came back to us recently. Again, the cytopenia part is there, partial recovery, and her spleen is still there. Not very good response, I'll say, but I think the sarcoid, they are not even expecting the drastic disappearance of things. She's under follow-up. But treated with that, and it was interesting, but I couldn't give them the complete closure. So I thought I'll discuss with you.
No, I suppose there are certain situations where you really can't close a case. There could be so many mystery.
Thank you, sir. Thank you so much.
Thanks for your.
And one point I would like to add, this could be especially for the institute like ours, where every 6 months a new resident will start reporting peripheral smear. One good point a lab should try to make is all cytopenias, fresh cases have to be reviewed by faculty, because otherwise we'll miss all the treasure of information which are there, which you beautifully
it's
showed
very
in your
important. Oh yes, I am fully for it. Whosoever busy faculty need to be there to train your, especially the junior PGs into identifying. So don't leave your PS reporting to the fresh rookies. They need to learn, and that's the role of the faculty. That's our job to do. So we must insist on it.
Yeah. Thank you, sir. Thank you so much.
Thank you, Dr. Richa. Dr. Nibajit, your question, please.
Thanks, Dr. Amit. Hi, sir. Really a wonderful talk. As always, was a pleasure to listen to it. And what beautiful cases. So I have one practical question and one theoretical one. So the practical question would be the difficulty we face, especially in adults, in differentiating aplastic anemias with hypoplastic MDS. You had showed those criteria scoring system as well, where you're scoring for dysplasias in the granulocytic and megakaryocytic lineage cells. We often we face a situation where we don't really get enough megakaryocytes or granulocytic CD cells to actually look for dysplasia, right? So you showed CD34 staining as well in a case where you had those immature cells. But sometimes we often we don't even have immature cells to look at to do a CD34 staining. So how often would you suggest a CD34 staining to differentiate these cases? Would it be in all cases or?
No, this I learned the hard way, because quite early I did miss an hypoplastic MDS. I had labeled it as an aplastic anemia. Those days CD34 immunohistochemistry was not very routinely being done with us. I missed it, and within 6 months, the patient came back with a frank acute leukemia. Then, when I went back, on hindsight, I realized, okay, I should have done a CD34 or paid a bit more attention. So that's what I say. Always look at your hotspot. After that, I became paranoid. I would any plastic marrow that comes, let's think of CD34. But that was also not the right way to do it. But just look at the hotspots, take a thin section, take deeper. Usually the blasts, the megakaryocytes and other dyspoiesis is not visible, usually, unless it's a very typical case. But I would say that you pay attention to that. And I'm sure with your experience, you will know that these are not normal lymphocytes. These look slightly weird. And you do the CD34. I err on the doing CD34 as often as I can.
Right. So when you're seeing something that is looking slightly out of the normal, you go ahead.
Either the density of cells are more, or the width of the hotspot is slightly bigger than what it normally should be.
Right.
Just pay attention to those. Those are the ones. Though the recommendation now is doing a flow CD34 immunophenotyping and seeing whether it's 2% or 5%. But that may not be very feasible as of now because.
Okay. Thanks a lot, sir. The other question is regarding the diagnostic criteria that we use for aplastic anemia. So here we often say that it's less than 25% cellularity, and they always give the rider that it could be 20 to 50% when the hematopoietic cells are less than 30%.
Yes.
So what is your interpretation of this, and have you ever had to use this for diagnosing aplastic?
No, thankfully, no. When you have an aplastic anemia, a frank aplastic without a cause, it's usually less than 25%. Most of the time, you hardly ever find a more cellular because maybe our patients come pretty late in the course of the disease. So this problem. The actual problem occurs in things like, let's say, PNH or chemotherapy-related marrow suppression, where, of course, the criteria doesn't really matter, but there you can get a bit more cellular foci. But so as usual in aplastic anemia, that less than 25%, I think, is there as a criteria. But most of the cases do fulfill that criteria. It's hardly ever I've seen aplastic anemia with good amount of cellularity to really infuse.
Right. Thanks a lot, sir.
Thank you, Dr. Nebajit. Sir, from the same note, also in case of aplastic anemia, when you get hypocellular marrow, you may also get erythroid hyperplasia.
Yes, you can.
And that is very difficult to differentiate from hypoplastic MDS. So
yes, definitely.
Because both can cause erythroid hyperplasia, starting phase of aplastic anemia as well as hypoplastic MDS. And how do you go with it?
That is there. Again, that's why pay attention to the hotspots, pay attention to those cells. Erythroid cells can be there in plenty. But if they are not immature, if they are showing features of maturation, that is definitely a dilemma. It's a problem. Okay, so you have to sort it out. Maybe CD34, E-cadherin, or some other erythroid marker. If they are too much in plenty, you might have to apply. So that is where aplastic anemia and that hypocellular, though these criteria doesn't talk of erythroid cells. Your criteria talks of only CD34, but you are quite right. In practical practice, the erythroid hypoplasia can also really cause trouble. Also, in the trephine biopsy, erythroid cells and lymphocytes look very similar. At times it becomes difficult. So that is a problem, and you will have to sort it out by the use of maybe ancillary techniques if you want to.
Thank you, sir.
If I may chip in here, I think we don't have the category of RCC anymore, right? The renal site.
Yes.
But earlier, when we had the criteria for RCC, they used to say that if there are erythroid clusters of more than 20 cells, it is more in favor of an RCC rather than aplastic anemia.
Yes.
I think that is something that we can keep in mind.
Thank you. Dr. Mahesh Mandalkar, your question, please.
Thank you, sir, for an excellent talk. It was a very informative talk. I had two questions. One is, in cases of severe pancytopenia, when the analyzer on some occasions do not give the proper counts. So can we resort to Buffy coat smear examination in these cases? That is one. And second question is, how do you get over a case of dry taps? Because aspirate gives a lot of information of the morphology, which we cannot obtain on a trephine biopsy. So do we have to resort to biopsy from two sites in such cases?
Okay. So first, current cell counters, I don't think really err on the cell counting, even if it's very low. Buffy coat preparation would help you identify the cells, what kind of cells, but then with a Buffy coat and spinning, the morphology gets distorted. So I think as far as possible, most of the time the cell counters do give us even very low TLC and very low cell population. The cell counts with a well-made peripheral smear should be enough in most situations. I'm not very sure of doing a total leukocyte count from a Buffy coat preparation. I don't know how reliable that would be. Okay. Your second question on dry tap. Generally, what we follow as a policy, we do an aspirate and biopsy at the same sitting. So in situations where dry tap occurs, if you make an imprint of the biopsy, that at times helps in getting the morphology. Suppose it's like a myelofibrosis or something that has caused the dry tap or metastasis. The imprint is always very useful to get the morphology. And the trephine biopsy is there for you to diagnose. You understand? So if you do it simultaneously, you really don't have to, and your biopsy is adequate and the imprint is good, you really don't have to do another bilateral bone marrow biopsy or biopsy at a second sitting. The problem arises when in places I know where they first do the aspiration, wait for the result, and then if it's a dry tap, then in a second sitting, generally avoided. I mean, both these procedures are technically similar, same needle you can use, or at the most in the same sitting. I think it's good practice to do both the procedures together. So each acts as a complementary tool to the other.
Thank you.
Thank you, Dr. Mahesh. Dr. Amar Ranjan, your question, please.
Good afternoon, sir. My issue was what is the in the definition you talked about platelet count as less than 1 lakh, and at many places it is written 1.5 lakh. What will be actually?
No. The diagnostic criteria for aplastic anemia is 1 lakh, less than 1 lakh. Normal platelet is 1.5 to 4.5, and between 1 lakh and 1.5 lakh, we will call it thrombocytopenia, but it is not a part of the criteria. You understand? Because platelets up to 1 to 1.5 lakhs really don't cause much of a problem. So for criteria of aplastic anemia, it is taken as 1 lakh. But truly speaking, normal platelet range is 1.5 to 4.5. Understand?
Yes, sir. I agreed, sir. Another thing you talked about a bone marrow metastasis, sir. Case of bone marrow metastasis.
Yes,
Bony metastasis is more common with respect to bone marrow metastasis. So what was the actually primary focus of that metastasis? Actually, I had
the
a case
particular
of
case that I
germ
have
cell tumor.
was a gastric. No, we have reported many cases with bone marrow metastasis. And in fact, my basic thesis was on bone marrow metastasis. If Dr. Tejinder Singh is listening, marrow metastasis is a fairly common occurrence. In some tumors, especially breast, stomach, then neuroblastomas, they all go into the marrow, sir. And this particular case that I picked up was, that I showed was a case of a gastric carcinoma. In fact, we have published this whole series. They were all in young adults. So this was a gastric carcinoma with marrow metastasis.
Okay. Thank you, sir.
Thank you, Dr. Amar Ranjan. Dr. Tara Roshipal, ma'am, you have another question? Dr. Tara Roshipal? Okay.
I think.
Don't have any questions.
Yeah, fine. So there are some questions from the audience.
Yes, please.
Dr. Hitha B wants to know, how frequently do you see autoimmune lymphoproliferative syndrome, that is ALPS, as a cause of cytopenia in clinical practice?
Not too many, though it is described. We have seen cases of the autoimmune myelofibrosis causing pancytopenia, but ALPS, I have actually not too many cases that I have diagnosed in a setting, so I really cannot comment, but whatever 1 or 2 ALPS that I had diagnosed did not show pancytopenia. But
Thank
it
you,
could
sir.
jolly well show. I mean, it's an autoimmune process, so it might as well show pancytopenia, I think.
Thank you, sir. And another question from Dr. Priya. How often do you find these LE cells associated with SLE in connective tissue disorder?
Yeah.
In
marrow. This was the first one I saw in the last.
Also.
Beg your pardon?
Both in marrow as well as in peripheral blood.
Oh, okay. In marrow, this was the first one, and very strangely speaking, another one turned up within a month or 2 in the department. So we have had 2 such LE cells. In the peripheral blood, when it was done as a procedure, the LE cell test, once it's an obsolete procedure now, what we did get it quite frequently, and most of them cases that we got LE positive in the smear were turned out to be actually SLE. So there was a very good concordance rate of LE cell preparation with SLE. Now that we have the auto antibodies being available, LE cell test being a cumbersome test has become quite obsolete. But those days when we were doing it, maybe about 10-15 years ago, regularly there was a very good concordance with SLE, clinical SLE and LE cell positivity in the smear. It is actually a very beautiful test. I mean, it tells you the entire pathogenesis of SLE very beautiful. Only thing, it is such a cumbersome test that we have given it up.
True, sir. Another question from Dr. Ali. Did you observe any change in incidence of pancytopenia during COVID pandemic and post-COVID?
No, I am not too sure. I mean, we have not really looked at it that way, but I don't think so. overall pancytopenias are on the rise. That is true, but most of it is possibly because of this chemotherapy, the oncological practice that we have now become. So that is probably the reason, rather than.
True. Another question from Dr. S.K. Sharma. Serum B12 is being done left and right in many centers these days, but folic acid is often ignored and are under-ordered. Do you feel folic acid has an important role in causing dysbiosis or pancytopenia and should be estimated as often as B12, if not more, because storage capacity of body for folic acid is much lower than B12?
That's true. Folate deficiency, folate levels need to be studied, definitely. And that is also an indicator of, causing megaloblastic. Both go hand in hand. I know we are doing B12 right, left, and center, and I don't know what is the result. We are finding a very high population of people with sub B12 levels, with very low B12 levels. So that is there. But yes, I think folate levels also equally, folate levels should be equally ascertained at the same time.
So is it a red cell folate or serum folate?
Ideally red cell folate. Ideally red cell folate. But then that again probably is more of text. I don't know how many centers are giving red cell folate. Most of the people do serum folate, which probably doesn't, it's not as good as a red cell folate. That's true.
The main problem is because of the cost.
Cost, definitely. And so basically what megaloblastic anemia now is an empirical treatment to treat, give B12 folate and wait for the response. And most patients do respond.
Absolutely, sir. And I think again, repeat question from Dr. Avinash Priyadarshini. What is the cutoff for the platelet count you already mentioned? Less than 1.5 lakh or less than 1? So because WHO...
That's what, for aplastic anemia, it's less than 1. Okay, for definition of pancytopenia, it is less than 1. So keep that in mind.
Otherwise, thrombocytopenia is less than 1.5 lakh.
1.5.
Yes. Fine. So I finished all the questions from the audience. Anybody wants to ask here? Dr. Ma'am, Tara ma'am, you have another question?
So just regarding the criteria for pancytopenia, some books mention retic count instead of hemoglobin. Which would you prefer?
Yes, the current one, if you see the 2024, they are both are equally, but hemoglobin is a better observed or a more regular test done, so that hemoglobin of less than 10 is taken as still the criteria. Some places have retic count less than 60,000 as another. The current ones say that 60,000 is also to be included, but for practical purposes, the hemoglobin, TLC, and platelet count.
Thank you, sir. Thank you, ma'am. Dr. Shweta Rajpal, your question.
So very nice talk, sir, first of all. So, sir, I had a scenario actually I wanted to discuss. Usually in patients of post-chemotherapy, of BLL, AML, once we receive the marrow at post-induction time point. So how do you assess for cellularity in that? Like, do we follow the same criteria of age minus 100 or do we actually different, we should follow a different criteria for that?
Difficult. I've thought about it, but I think we presume that the marrow is going to be hypocellular. So
yes.
Situation where the marrow is cellular probably is an APML post therapy. You might get a very cellular marrow, but most of the time it is hypocellular.
Yes,
but your point is well taken. I need to think about it, but I think we would report it the same way that we report any hypocellular marrow, age minus, because it becomes difficult, especially in adults.
Yes, sir.
How to assess the marrow. For a child, it's fine. You can make it out because for an adult or a slightly elderly person, saying whether it's hypocellular, but yeah.
Actually, what happens is that we once we get the marrows where we have such cellularity, usually it is hypocellular. But if we report hypocellular, then we are giving an indication to clinician that there is something wrong, right? So somewhere I have read that even if the cellularity is more than 20%, you can give normocellular for for
the clinical condition. Yeah, maybe that is better. You have to add a rider.
Yes, yes,
and
sir.
When we are looking at a marrow post chemotherapy, I pay not just attention to the cellularity, you have to pay attention to the cells.
Yes,
whether there is regeneration going on.
Correct, sir. Correct, sir.
So that is also an important aspect. So just by labeling it as hypocellular, you are right. We should not label it as a hypocellular marrow, but always have a rider that this marrow is regenerating. or
Yes,
it is
yes.
totally, there is marked suppression of all the cell lines. So that also has to be taken
Yes,
care of. So when you're reporting it out, add those points also.
yes.
Right.
Thank you. Thank you.
This marrow will do well, this marrow will not do well. That thing, sort of a thing, is useful.
Thank you, sir. Thank you, Dr. Sweta Rajpal. Any other want to ask? Yes, Dr. Vidisha Mahajan.
So a very basic practical question. So sometimes we get these suboptimal bone marrow biopsies where you do not get those 5 to 6 spaces required to label it as an aplastic anemia, but it's coming from a center which would rather not repeat the biopsy. So in such cases, what do we do? We have just 2 or 3 we have the subcortical space and 2 to 3 marrow spaces which show decreased cellularity. So in such cases, how do we report it out?
Yeah, don't be dogmatic with your report. Give it as a rider. The marrow is inadequate or insufficient or suboptimal in adequacy, and then go ahead and describe it. Always tell your clinician that this could be aplastic, but I am not 100% sure because the length is small. So keep that as a note always in your report, that this is a suboptimal biopsy on which I am reporting. So if you have that, you are in a better position to defend yourself or discuss the case with your clinician. You would rather, also you can write, it would be worthwhile to repeat a marrow. Put that as
before
your
labeling it as an
statement.
aplastic.
Yeah, before labeling it as a class. So it appears to be like an aplastic anemia. However, the length of the marrow is suboptimal or it's not adequate enough. It would be worthwhile to repeat a marrow if indicated. Something like that you can add into your report.
And a second situation, sir, which we commonly face here is that we have young patients who come with basically there'll be a cellular marrow, but only some areas of fibrosis. But those fibroses are paratrabecular. So how significant that is that? There's no other reason for a fibrosis in the marrow, sir. So we see a lot of these patients coming from the government hospitals. There's a paratrabecular fibrosis, rest the cellularity is on the lower side. So any experience with that?
Yeah, I mean, whenever I have not really encountered, but whenever there is paratrabecular fibrosis, it is kind of abnormal. It's not a normal situation that you will get paratrabecular fibrosis. So I think if it is documented, if you have a good marrow and you're showing paratrabecular fibrosis, and otherwise hematopoietic suppression also, think of certain conditions like renal diseases. Those are, you may not be getting the information. Clear-cut clinical information may not be available. So keep that in mind, that it is abnormal. If you are convinced that it's a paratrabecular fibrosis, then it is not a normal thing to see. Unless there is a crushing or something in the marrow biopsy, which is causing some kind of a false impression. But if you're sure about it, paratrabecular fibrosis is, I think, not a very normal finding. And one of the causes of paratrabecular fibrosis is renal failure, without chronic renal failure, kidney disease.
Thank you.
So just pay attention to it. I mean, it's not that you should ignore. That's all. That's what I can say.
Thank you so much.
Thank you, Dr. Vidisha. Another question from Dr. Lee B. Sun. Why is iron stain increase in marrow of aplastic anemia cases?
One, they may be on transfusions. And second, generally the process of the cell death that occurs, a lot of iron is released, intracytoplasmic iron, macrophages are activated. Because after all, aplastic anemia is also kind of an immune-based disorder, right? So there is both lymphocytes and macrophages. If you look at it, iron levels are quite high in the macrophages, hepcidin related. There is an iron overload anywhere in the body, as well as because of maybe transfusions patient may have received.
True, sir. And what about iron stain in hypocellular MDS?
Hypocellular MDS iron stain. Yeah, it is very, very important. If you are getting, especially on a marrow or ring sideroblast, you can pick up. So iron is a useful stain to do in MDS. And it is often elevated and increased in trephine biopsies. But if you have a case of aplastic anemia and you're finding ring sideroblast, then that's something that you need to look into.
True, sir. Another question from Dr. Nikita Jakar. She wants to know, could you please highlight when to suspect PNH clinically and on peripheral smear in an underlying case of aplastic anemia?
Okay, generally more than 40 years. The peripheral blood shows a few polychromatic cells. Few may even show microcytic hypochromic. The absolute lymphocytosis or lymphocytic predominance that we get in aplastic anemia is not there. There are a good number of neutrophils, a slightly elevated retic count. So all these things should make you suspect, because also look for history of if you get jaundice or passage of urine, which may not come always, because hypoplastic PNH, you may not clinically pick it up that way. But peripheral blood, these are the, I discussed that in that case of mine. So polychromatophils, reticulocytes, microcytic hypochromic indices, because with hemosideruria, iron gets lost. So, and neutrophils not as suppressed as you get in aplastic anemia. So these are your little clues. Generally, above 40 years, it's a good practice to at least do a urine hemosiderin. That is a very easy stain to do. So if you're, even if it looks like a frank aplastic anemia, there's no harm in doing a hemosiderin stain or the pearl stain on the urine sample. And you can go ahead with that.
Anything about LDH, sir?
LDH is elevated. Elevated, yes. LDH is on the higher side than frank aplastic anemia. Yes.
So another question from Dr. Nivedita Devabrata. In a case of pancytopenia, what is the criteria difference for male versus female in the hemoglobin levels?
No, 10. It's 10. Whether male or female, less than 10.
Perfect. Thank you, sir. Dr. Shweta Rajpal, do you have any other question?
No, thank you.
Dr. Nebajit?
Yeah, I just want to ask, sir, in your when you're showing the case of storage disorder, you had also shown sea blue histiocytosis as yeah.
No, not that. That I had shown a sea blue histiocyte.
Right.
How it looks.
Right.
I have not seen and encountered the case of sea blue histiocytosis so far. It's commonly seen in CML.
Right, exactly.
That was not a case, not to show a sea blue histiocytosis case. It's just to identify the types of macrophages.
Right, sure. Thanks.
Yes.
Thank you. Someone name is Savipat. Again, you put your hands up. You can speak your question. Savipat 8. Okay. It's fine.
Please unmute and speak.
Yeah.
Okay, or maybe, I don't know. All right.
Fine. So, sir, I finished all the questions from the audience. Any other listeners want to ask any other question? So
Sunday lunch, let people break.
True, sir. Sir, thank you so much for that fantastic and lovely talk. It was worth listening to you, and a wonderful discussion we had with you, sir. I think you showed
Yes, that was very nice. I mean, all of you chipped in. Good.
Thank you so much, sir, for being our teacher today. Thank you so much. And I now request Intas Pharmaceuticals, Vastavikta, to please go for final vote of thanks.
Yes, sir. Thank you, Amit sir, and thank you, Dr. Basu. As everyone mentioned all over the session, that the session was so meaningful and insightful. We had plenty of questions, plenty of people being involved. So thank you so much, sir. Thank you to the organizers. Thank you to the MHG group for providing us this platform where everyone can come up together and discuss such insightful things. And thank you once again, sir. Thank you, Amit sir, for moderating the session and being such a wonderful host with for today. And yes, thank you from our side also. And we'd like to conclude the session and we'll see you in the next session. Thank you so much, sir.
Thank you very much.
Thank you, sir. Thanks, sir.
Bye-bye. Take care.